This
or
conference will now
somatic,
be recorded.
what they call a somatic mutation, which is the mutation that's occurring just in the tumor, not in the rest of your normal cells.
Is that done by blood test? Do you
Sorry?
know? Is that determined by blood test?
Well, you could determine the germline mutations from a blood test or saliva, either one. But the tumor mutation has to be done from your biopsy, and
Okay,
that's yeah.
that's what they're doing. They have ordered my biopsy material tissue from my doc. I think that's what they're up to. I don't know the terminology. They haven't said exactly what, but I think that's what they're doing.
So I have a question for you, Len, because I
Yeah.
always get confused on this. Is there a significant difference between sequencing the primary using a sample from the prostate versus sequencing from a metastatic lesion?
Yeah, there certainly could be a difference because the primary tumor is the area where the seeding occurs, the seeding of the metastases. So I'll use my own case as an example. When I had my prostate biopsy, I had 7 mutations, somatic mutations or tumor mutations. Years later, I had a bone tumor genetic sequence done, and it only revealed 1 mutation. So, it's possible that, and as a matter of fact, I had the BRCA2 mutation in my prostate, but in the bone lesion, there was no BRCA2 showing up. So you can get different results. Was that what you were asking, Rick? Or
Yeah, because if it were you were in Steve's shoes and you were sending a sample to Foundation Medicine, would you want to send your prostate tissue, or would you want to send your tissue from one of the metastatic lesions?
it's a good question. I'm not, not sure what the right answer is, or if there is a right answer. Of course, ideally, it would be good to sample both sites.
Yeah,
Is that done through a bone biopsy, the bone lesion?
yes, it
Yeah,
is. And
I
which
will
is
ask about that.
yeah,
yeah.
which is not a Len, would you like to explain very quickly the bone biopsy procedure since you've been through it?
Yes. So I went to the NIH for a bone biopsy after I had, well, initially I went to the NIH for an experimental, highly sensitive PSMA scan called PYL. That revealed several bone metastases, and then subsequently to make sure, since it's an experimental scan, they wanted to make sure that what the scan is picking up is truly a positive prostate cancer metastasis. They biopsied the bone, and it was positive. Now, how they did that? They put you into kind of a CT scanning tunnel, and they have a fluoroscope up on the side where they can see where the lesions are, and then they, in my case, the lesion was in my hip, and so they take a little hammer and chisel, get the needle started into the bone, and once they have a little opening there, then they insert a biopsy needle directly into the lesion, and periodically they move you in and out of the CT tunnel and they're looking at the fluoroscope screening. And so they took a couple of samples, and that's it. At first, I opted for no anesthesia at all. But then when they were banging away with the hammer and chisel to get into my bone, my whole body was kind of shaking. I said, you know what, guys, maybe you can give me a little fentanyl just to take the edge off. So they did that, and it was painless after that. And the recovery was absolutely uneventful. They kept me under observation for about 2 hours in a room, and everything was fine, and they let me go. And I just, walked out on my own accord, took the NIH shuttle bus back to the hotel. So it's not a big deal.
How long ago was that, Dan?
July of 2019, a little less than a year.
Yeah, it hasn't been that long. Yeah. Okay.
So,
Because they want to put you under for everything today.
Yeah, that was an option, but I said no, I didn't want that.
so I want to keep moving this along because I do know we've got one other gent here. Who else might want to comment before we try and pick up some loose ends for Steve?
I want to talk about a little bit about clinical trials because I did participate, and or I guess I'm still participating technically. And in my particular situation, it was a randomized trial. So you're in part A or part B. And I was always told up until I ultimately decided to go through and participate that I could always drop out. So be aware that when they're mentioning a clinical trial, it could be something where you would be randomized as to whether you would receive the treatment or not. So something to consider.
Well, they have that that I will not receive a placebo, that I will receive the drug, and that I can drop out of the trial at any time. That's what my oncologist told me.
Right, and I think we should point out because Len and I both looked at the trial. What the determination of where Steve will be is going to be indicated by the result of the tests that he's going to do, and the treatment is, I think, the same in all three arms. So so all three arms are getting docetaxel and nivolumab, but Carl still raises a good point. Peter, you wanted to say something.
Yeah, Steve, did they talk about second line anti-androgen like you or anything, since your PSA is climbing? Or is that make a trial not applicable for you?
No, they haven't mentioned anything about that. That test for my that showed my PSA rising to 7.3, I think. I haven't met with my doctor since that came in, so maybe he'll have a different something different to say about it. We're supposed to meet next Thursday. I'm sure he wants to talk about the clinical trial. I'm going to be his initial patient into this trial. It's run by Dana Farber. And so I might have mentioned this to Rick. I feel like he's kind of courting me, because he wants to contribute to this trial. And I really didn't know a lot about all this when I first met with him, and he talked about it, he brought it up. There wasn't a lot of this detailed discussion. Of course, I wouldn't know much about it anyway, as far as what the options were, or even what the objective was. So this is something that we're going to really get into next week. So that might be something that we'll talk about. But I'm really having second thoughts about doing it. because I know there are other immunotherapy drugs that are out there that might be suitable for me later. But you know, I think I got enough to handle just adjusting to the Lupron and then going on the Docataxel. I mean, I think that's, I just don't feel comfortable about taking an additional drug on that I don't know much about, or maybe none of us do, but at least I am assured in the sense that they're following the course that I see are mostly followed in a case like mine. This is where they're going.
So Steve, I'm presently doing chemotherapy, but I'm also on a second-line anti-androgen, according to Beckwith. But it's pretty common to take a second-line drug like Zytiga, or there's numerous ones, even if you're going to do chemo. I don't know about the clinical trial. It might preclude you from doing a clinical trial. I'm surprised that haven't even suggested that if your PSA is going up.
Okay, so let me just intervene there. I don't know that it's pretty common. It is for the people where you get your treatment, but I think in most cases they'll start you off either on one or the other and not both, because they're very concerned about the side effects of giving them both at the same time. That's not true of prostate oncology specialists for sure. But if you listen to some of the videos and the discussions, it's usually one or the other, and they determine which one to start with. Now yours is you're a little different situation because you did the chemo much later in the process, and you were already on an anti-androgen, and they didn't stop the anti-androgen. But I don't know too many people that have started on both second-line anti-androgen and docetaxel. I think that's something that they tend to do more in Marina Del Rey. Who has started their treatment on Lupron and docetaxel? Anybody on this call kicked off their treatment with Lupron and docetaxel?
Rick, Dennis.
Beginning, you mean?
Dennis,
My husband.
Beginning.
Similar start as you. I had Gleason 9. I don't think I had as many metastatic sites as you did, but it was over 5. And basic standard of care for a disease like that has gone beyond the prostate needs systemic treatment. And that's docetaxel. And that's what I started on. And like you, started the first injections of the ADT drugs to stop the testosterone, and that was Permagon. And then very quickly switched to the Lupron. And then things were good. The PSA was coming down. Then shortly after about a year, slowly started creeping up again. And when I went back in, I got some more tests done and so forth. They did see some new tumors starting, which meant that I needed a second-line anti-androgen such as Zytiga. And the Zytiga has brought me down now to less than 0.1 on my PSA. And all my scans have been showing size of lesions and liver metastasis shrinking. So, I mean, I would not jump into a clinical trial at this point either. And I didn't get the name of your doc, your primary doc. Is he a genitourinary oncologist?
Yeah, he's a medical oncologist. His name is Gabe G.E. Chahoud, C-H-A-H-O-U-D. He's 11 years.
You met on, yes.
Genitourinary oncologist?
Yes.
Yes, he is. Let me move. I want to just keep moving. I'm sorry. I love to sort of keep it unpacking with everybody, but I'm just wary of time and all the people. Dell, do you want to talk about what your experience was with starting with Lupron and docetaxel?
Rick, this is Jerry. I just had one question for Steve because I didn't hear any bone medicine.
Okay.
I didn't hear like.
Good point, but let's just stick with the one thing at a time, then we'll come to you. Okay.
No problem.
Very good, Jerry. Dell, why don't you just talk about your experience starting on Lupron and docetaxel?
My experience was a pretty positive one, in that I started at the University of Iowa, and that was the immediate initial treatment was the Lupron injection that day and chemo the first day. And they also gave me the pills, which I think is the Firmagon to bring the testosterone down for the initial to prevent the flare. And then it wasn't until my fourth chemo that I also needed to have Neulasta for the blood cell because my white cell was counting. I was starting to get infections. And so that's something they always got to keep an eye on and something you got to, but otherwise that experience was what got me prepped for surgery. So,
Right.
and I had metastatic and I also have a Gleason score of 9.
Yeah. So two things, and then we'll wrap it up. One is that it is much more common today to treat the primary gland either early on or before too long. A lot of the guys, we've got 2 gents on here who had diagnosed de novo metastatic and had surgery subsequently. And we've got a bunch of guys who have had radiation to the gland because there's a newer trend of thought that it is important to remove the primary source of the cancer, whereas in the past it was thought that that did harm, and in the spirit of do no harm, they said no, we're not going to treat it. That's changed over the last 5 years, and that's something that, whilst it may not be on the table right now, and probably for you, I mean, if it were me and I was in that situation, I would opt for radiation, but we've got some guys did radiation later on, like Ken Anderson, and we have somebody else, I don't think they're on today, or like surgery, which Carl did in that clinical trial and which Dell did, but it's something that needs to be raised. And then Jerry wants also something else that he wants you to raise, which is a very good point. Go ahead, Jerry. You're muted, Jerry.
There I go. I am a Gleason 9 like you. I was diagnosed February of 2019 at Mayo Clinic in Phoenix. And I did the month of Firmagon and then on to Lupron. But what I was wanting to ask was my medical oncologist, because of my total spine and some pelvic lesions, he put me on Zometa, which is a drug that helps build your bone. And there's another one called Xgeva. And Xgeva is newer than Zometa, but that's all I wanted to tell you, because my PSA was 3,193 at Mayo. Yeah. So my spine is pretty well gone. And I've got to be very careful about a spinal collapse or even falling and breaking something. So anyway, that's the only thing I wanted to bring up, Rick, was...
That's fine. Well, look, Steve, you and I can talk some more. You can talk with Len. Let me tell you where I come out on this. Your disease is unusual, but we've seen it before. It's unusual because you have extensive metastasis and you don't make PSA. And I would say 1 in 10, maybe less, of the men somewhere between 1 in 10 and 1 in 20, we see men who don't make PSA and who have disease, and some of them more extensive disease. Not always, but often it can signify that there's something strange going on with your disease. And if we were able to identify what that was early on, it may help you choose the right treatment. And whilst normally we don't recommend that you get sequenced very early in the game, somatically sequenced, not talking now about the germline test, but we don't recommend you get somatically sequenced that early in the game. There may be a reason for you to do it because there may be some mutations running from very early. What often happens with these mutations is that they're not there at the beginning, but they develop in response to treatment. Now, I think if I were you, I would probably wait and see if anything comes back in your germline test. Do you have any history of cancer in your family, Steve?
My mother's half brother died of prostate cancer, and I always assumed that that was not a factor because he was a half brother, but apparently that is. So that's the extent of it, really.
Could be, but no, with the women, no ovarian cancer or breast cancer or anything like that.
No.
No. So you may not see too much in the germline. If you didn't see anything in the germline, it could be an option for you to pursue, or to see how you do on the Lupron and the docetaxel. There are specific markers that are going to indicate whether you could respond more favorably to the nivolumab, the Opdivo. If it were me and I was thinking about doing Opdivo, I would want to know what those markers are first. I wouldn't just do it rolling the dice. If I thought I was going to be receptive to it, then I would do it. Like you say, there's always going to be, not always, but the likelihood is there's going to be trials going on for a while. Would you be eligible for the trial? No, because you'd already done the docetaxel. I think it's very smart to do docetaxel up front. It's in fact what NCCN and others recommend for somebody like you right now diagnosed with high volume metastasis. And I'm sure you'll do quite well with it. It's not an easy treatment. There's a bunch of guys on this call right now that have done it, and we will support you and get you through it. I know we can do that. At the same time, I have the reservations that you have, that to add another treatment, especially something that could be as toxic as an anti-PD-1 immunotherapy drug, is difficult. And,
right, well, let me just say, because I don't want to dominate the conversation here, and you need to move on, but just in regards to the bone part of it, I did meet with a oncologist at Mayo Clinic. I had a consultation with him, and he recommended the same exact treatment that Moffitt did, except he did have a bone therapy component. So that is something I'm going to address with Moffitt. I'm kind of sticking with Moffitt because they're local and you're close to me. I can drive over there in 30 minutes. So I'm going to address that and this. I think maybe Moffitt has not brought it up. I don't know if this is relative, but the fact PSA is relatively low, that they don't think that bone therapy is a important factor right now. But I have read from the literature that it is an issue that you need to be aware of and keep an eye on. So I'm going to ask for a bone density baseline test just for right now, and then so they can monitor me for possibly having osteoporosis at some point.
Yeah,
So
that's important. I mean, I was osteoporotic on diagnosis, and I actually did Zometa, not because I was metastatic, but because they were concerned about my bone density. And I think it's important. I think it's also important for you. PSA's got nothing to do with it. What's driving it is the amount of bone metastasis you have. And in your case, you're doing it because of the bone metastasis and not because of the bone strength, but the bone strength may be an additional factor. Let me finish up by going to Len. Len, is there anything else that you'd like to add to put on the list for Steve to talk to his doc about?
I don't think so, Rick. I think you covered it good.
Okay. So, Steve, if you talk to me or Len before you go in, we can help you. Very important, write your questions down and hand the doc a copy of your questions. Okay? That way, all the questions will get answered. Don't have too many questions, probably maximum 10. We can help you figure out the questions. But by sending him a copy ahead of time through the portal or handing him a paper copy, that way all the questions get answered. It's good. A lot of people like to record their conversations with the doc. Sometimes it's good. I assume that Alana is going to go with you. Is that a fair assumption?
Oh, it's going to be via Zoom. So yeah, we do them all together. Yeah.
Perfect.
Yeah. And I did pull down off the internet from, I think it was the National Institute of Health, questions in regards to clinical trials. So I do have a set of questions I'm going to ask him.
Okay.
Or I'm going to provide him ahead of time.
Okay, so we got to move on, and the next gentleman we're going to talk with is Ron Chin, who again I spoke to at length yesterday. And maybe Ron, it might be easier again if I summarize. How would you feel about if I summarize and then we can ask the guys what they think, and you can ask them any questions you like? Are you with us, Ron? I see the microphone is open. No? Are you there, Ron? Jeff, are you with us?
Hello, yeah, I'm here.
Do we know where Ron is?
No, let me see. I'll try calling him. We'll probably get a busy signal.
So I can see an initials there, RC, and I
Right.
can see a green light and he's with us on the phone, so he should be able to hear us.
So I will call and see if I can raise him.
Okay, why don't we do that quickly, and if not, we'll try and make some time for him to go through his history and to help him. Okay, I see there's some vibrant conversation going on in the chat window here. Here's what I'm going to do. And then I'm going to do the roll call to see how many people would like to speak today. And then if we can raise Ron, we will talk to him before we start. So I'll start at the top. I hope I've got everybody on the list. If I don't, you'll let me know. So Rich Jackson, anything for you today, Mr. J? Haven't heard from you for ages.
PSA update, now 2.4.
Okay, hold on. We'll come back to you. We'll come back to you.
That was it.
Okay, well, all right. Jeff, well, I won't ask Jeff. He's busy doing something. Peter, anything for you today? You're muted, Peter.
I'm fine.
You're okay. Good.
Fine.
Okay. Peter Monaco, anything for you?
No, Rick, I'm good.
Okay. Dennis, anything for you today?
If you got time, I have a 1-minute comment.
Okay. Jim Ward, anything you'd like to talk about today?
No, thank you, Rick.
Okay. Len, anything for you today?
Nothing, Rick. Thank you.
Les Shelderup, anything you'd like to talk about today?
Not today, thank you.
Okay. Paul Frieder, anything for you?
Nothing for me tonight.
Okay. Russ Smith, anything you'd like to talk about today?
Just 3 minutes, maybe.
3 minutes, okay. Okay. Sylvester, anything for you?
No, thank you.
Okay. Ken Anderson, anything you'd like to review? Ken Anderson? I think he must be driving again. Okay. If we don't hear from Ken, I'll check in with Ken one more, but he's probably driving again. Dell, would you like to give us a quick update since we haven't heard from you for so long?
If you have time.
We have time. Carl, anything for you?
I guess the follow-up to last week about MIRA, I don't know if you had any additional information for me about that drug.
Remind us again, what was the drug?
MIRA?
Oh,
Yep.
no,
Okay.
I don't have anything more for you on Famara.
Okay, nothing else.
Okay.
Don't forget Jake, by the way. You haven't called on Jake yet.
I've got Jake on my list. I've got him down here. He came in late, so he didn't get on at the beginning. That's what happens when you don't get on the beginning. Scott Hogan, anything for you today?
30 seconds when we come back. Thanks, Rick.
Okay, we'll be back. Greg Haskin, are you still with us? I see you've been in and out a couple of times. Are you with us now? Where are you, Guinness? Okay. All right. Greg's great. Well, if I see his face, I'll come back to him. Larry, anything for you?
No, thank you, Rick. I'm good tonight.
Jerry Pelfrey, anything for you?
No, thank you. I'll do it next week.
Okay. Jake, anything for you?
No. Thank you, Carl, for looking out for me, but no, Rick. I appreciate it. We have somebody on telephone, caller 3.
Well, I'll get to them right at the end if I may do, but thank you for pointing that out. Let's see. Joe Blanchette, anything for you?
Just a couple of minutes. I got a message from Dr. Narakis.
Okay. Barbara, anything you'd like to talk about today?
Yeah, I do have a question about PSMA and biopsies. It probably won't take too long, but I want to hear what all you think.
Okay.
My husband just had a bone marrow biopsy, a bone biopsy, by the way, and I'm questioning whether they
we'll
tested for enough.
Okay, we'll be back to David Muslin. Anything for you today?
2-minute update, Rick.
2-minute update. Okay, now, Jeff Dreyer, anything that you'd like to talk about for yourself?
For myself, well, I'm sorry Ron seems to have dropped off here because I've been talking with him for the last few days, and sounds like he really would like some guidance and support.
Jeff, can you hear me?
Yes, you are.
Okay,
I hear him.
Good. Okay.
Do we hear him?
Okay, we can hear you, Ron. We'll be back to you. Jeff,
okay, don't go away now, Ron.
Don't go away, Ron. Stay by the phone. Jeff, anything about yourself that you'd like to update us on?
Oh, I can say a quick update after some confusion.
Not right now. Not right now. We'll be back to you. Okay.
Okay, sure.
Okay.
Optional quick update later.
Okay. And is there somebody on the telephone that we haven't identified? Anybody on the telephone that hasn't identified?
Jim Strait, got on late, listening and learning.
Oh, Jim Strait, listening and learning. Okay, Mr. Strait, we're very, as always, I should tell everybody that Jim is it the vice chair or the chair?
I'm honored to be serving as chair.
Chair. Jim is chairman of us too, for those of you who don't recognize his name. And of course, we are and honored to be a partner of us too in doing what we're doing today. So thank you for attending, Jim, and let us know if you've got any questions. So let me.
Well, and Rick, thank you. Rick, thank you for all you do as well.
Oh, thank you very much.
Rick, I think Ken Anderson's back with us.
Oh, Ken Anderson, are you back with us?
Yeah, I don't have anything today.
Okay, all right. Now, Ron Chin, if it's okay by you, because I think this might be the best way to do it, I want to give the guys a quick summary of your background, what we talked about yesterday, and then open it up and let them talk, and we'll take about 10 or 15 minutes with you because we've got a lot of people to get around, if that's okay.
Okay.
Is that okay?
That's fine. What I've got to say is very sketchy and vague because, well, I'm stupid on all this.
Okay, well, that's why I think it'll be helpful if I do the summary.
That's right.
And then the guys will comment. I'll try and hit on most of the key bits. Okay.
Sure.
So Ron is 75, and he was diagnosed back in August of 16, so he would have been plus or minus 70. He now lives very close to where I used to live, and it just so happens that I know several of his treating physicians. Some of them actually personally, because one of them was a rower, and I used to see him quite frequently in the rowing club. He was diagnosed with a PSA of 400. Not sure what his Gleason is. He was going to do some research into that, but at the time, at age 17.
I have a guess that it was, and it's only a guess, of about 7 or 8.
Okay, 7 or 8. He was diagnosed by a urologist. The urologist chose to give him Lupron for 12 months. And at that point said, we're not getting anywhere with the Lupron. I think we should move him on. And they moved him on to a community medical oncologist who happens to treat a lot of prostate cancer patients, but he is not a GU medical oncologist. And they scanned him. This is in 2017, and they saw a fair amount of bone metastasis. They put him onto abiraterone, and the abiraterone failed after about 6 to 8 months. PSA got up to 1300. I don't know. I don't know. I never asked you, Ron, but when you first went on the Lupron in that first year, when Patrick was treating you, did your PSA drop? Do you remember or not?
He did.
Oh, it looks like we just got cut off from Ron.
Yep.
Well, I'll finish the story in case Ron comes back, and if he does, we'll stop by him. So, and I'm leaving my excellent bird dog Jeff Dreyer to track him down and see where he is. So PSA was around 1,300. They put him on to enzalutamide. It brought it down to around 800. And slowly over the last couple of years, it's risen back up to around 1,300, 1,400. At the beginning, the end of 2019 and early 2020, he thinks 3 cycles of docetaxel. He's not sure. Metzger determined, the oncologist determined that it wasn't doing anything. As I told him yesterday, sometimes it can take 3 cycles before it even has an effect. They did some germline testing. We don't know what the result of that was. He has had some palliative radiation. He's doing about 10 sessions altogether of spot radiation with an excellent radiation oncologist. But just a couple of months ago or less, the oncologist said to him that there was nothing more that could be done and he had 6 months left to go. And so that's the point at which I guess he spoke to Jeff and he came to us. And what I have done is strongly recommended to him that he gets a second opinion and maybe shifts his care to UCSF. I've given him the name of 3 doctors at UCSF, 2 of whom I know personally, the 3rd I know by reputation, and suggested he sees one of them quickly. He's a little reluctant, I would say, whilst he's doing his radiation and he's tired in the morning and what have you. But as I said to him, look, if you only have 6 months, taking another week or 10 days is a long time. So I don't know where he is, if he's done anything today or not. My feeling is that there could be other treatments he might be suitable for. There could be other chemotherapies. You know, we don't have any information about the sequencing of his tumor, which he desperately needs. And I guess that's where I'm at, and that's where I would throw it out to the rest of you. Does anybody see is Ron back with us? I guess not.
He's calling in again. He says I don't know. Yeah, he got dropped. I don't know why he didn't call back, but now he's trying again.
Okay. So here's what we'll do in the interest of time. Hold the story in your mind, please. And when he comes back on, bear in mind this is a man who's never advocated for himself, has not kept good records, and has suddenly been told he's got 6 months to live. Some of us on this call know that there are different options that are available. And who knows whether he has 6 months to live or not? We don't know. That's the view of Dr. Metzger, but I don't know if it's the view of every doctor. When we see Ron show up again, we will put him in the hot seat and we'll give him a little support and therapy. In the meantime, let us start off with Dell Jensen, who I will remind you was diagnosed at a young age and opted for very aggressive treatment. I'm trying to remember how long ago that was, Dell, but maybe you can tell us. And I also suspect you're probably you're another one of these guys who's teaching from home right now. How's the online teaching going?
It's been rough. So diagnosed in June of 2019, PSA 220, Gleason 5+4, 80% involved. My prostate was 80% involved in tumor. went to Iowa, was told that surgery was not an option, that the standard care of treatment was for metastatic was docetaxel and the Lupron, Eligard, whichever one it was. And then I came to ANCAN, and it was suggested that I go to Northwestern and see Alicia Morgans, who I understand is a favorite among this group. And if you go onto the website, you see her all over the place. And she agreed with me. You are young. We should do as aggressive as possible. She connected me up with Dr. Kundu. After my radiation was finished, they said, yep, you're a candidate. Had surgery January 8th. 2 nights in the hospital, and just a note, all through chemo, my PSA came down to about 4, but never really dropped below 4. And it wasn't, well, my last chemo, it did drop down to below 4. It was 2.75. At surgery, it was 2.6 or somewhere out there. After surgery, a month after surgery, it was down to 0.2, and 3 months out, it was undetectable. And
Wow.
then,
Congratulations.
yep, and yes, and so right now I'm waiting for radiation because the margins weren't clear. There were some, but as far as Dr. Kundu was, he got everything that he could see without putting other structures at risk. And so he went ahead and stopped where he was. He said it was because the prostate was so involved and the chemo did its job, it made it just a soupy mess, real difficult for him to do. But he was as successful as he thought he could be. And so I have an appointment with a local radiologist who's going to do 35 treatments, fairly low-level radiation as a follow-up for the residual unclear margin. So, yep, you're right. And I was diagnosed at the age of 50. I had just turned 50 in May. So,
have you talked to Dr. Morgan since your surgery?
yes. She liked the outcome, and she said she recommended the follow-up radiation. And she said, nope, you don't have to come here. Any local place can do a pretty decent job because it's not to eradicate the tumor. So it's really just kind of a lower level of radiation that I would be treating just the local region in the prostate bed. And she says if I have any complications in the future, to come back and see her. But she didn't really think there was a big deal about it. I have an appointment at the end of the month as a follow-up to my surgeon. And so there it is. So.
Wow. I mean, this is a great story, Dell, and we're really, I personally am truly happy for you that this is going the best way. I'm curious if they are going to radiate just the bed or they're going to radiate across your pelvic girdle.
I have not gotten into the specifics. Like I said, I originally had an appointment with him back in March, or was it the end? Yeah, back in March to get to know him and decide whether I wanted to work with him. And then we had set an appointment up for April 15th to start scheduling the pre-scan and the modeling. I guess they do a CT scan and then he put all the markers on you and all that. And then that got postponed. They were going to postpone it a month. And I said, well, why don't we go ahead and have 2 months? Because in April, I was starting to see significant improvement in urinary control. Okay. And so even now in the last month, I've seen even better urinary control. I think I'm probably 95% where I was before.
So here's what we're going to do right now. I'm going to say to you, check with them and check with Alicia whether they want you to do. She thinks it should cover your pelvic girdle or not. And I would say whatever she says goes. And okay. have you talked to Russ Smith, who is going through exactly the same radiation right now? And he's in the middle of it. So he can tell you what to expect. And he's also a younger man, not quite as young as you, but younger than most everybody else on this call. And Dell, you have to show up on the young guys call because they have a great time.
Jeff, I'm back again.
Okay, hold on, Ron. We'll be back to you. Don't go away.
I won't.
Russ, talk quickly about what's going on, your experience, and see if you can get Dell Jensen to come on your under 60s call.
That's definitely a great call. I mean, this is a phenomenal call as well. But it's good to be on with guys. I was diagnosed at 57. I'm now 59. Had the radical prostatectomy just over a year and a half ago, and the PSA kept rising, so I'm 11 days into radiation and 2 months into ADT, and I had a great weekend, and coming back into the day was not such a great day. So you're gonna have great days, you're gonna have down days. But the whole experience is not terrible. The radiation itself is not bad, but you get fatigued and your appetite changes, and trying to balance when you go to the bathroom and when you start drinking water, and all that's a challenge, but it's something you learn. Like I say, I'm only 11 out of 40, so I'm still learning.
Okay, anybody else? I'd love to spend more time with Dell, but we've just got to, in the interest of time, we've got to keep moving. Who else would like to say anything to Dell? Because I'm sure other people are as thrilled as I am.
Exercise.
Good point.
Yep.
I'm trying to get back on the exercise. The chemo really took it out of me, and then I followed that up in less than 6 weeks with surgery.
I'm going to probably have to take off because I have to do something with Barry before he goes to bed. I want to interrupt you though. Thank you, man. Every time I hear a story, every time I have to take off a little early tonight, but every time I hear a story, it gives me more information for being a caregiver to Barry. So thanks.
Let's do this, Barbara. Then let's elevate you, and then we'll go to Ron Chin. You had a question.
I can't hear you. I'm afraid I'm having something with.
Can you hear us now?
Thank you. Okay, I would have preferred if needed. The question is this: Barry finally got a successful bone biopsy, and for the record, he did the surgeon, the oncologist, wanted the biopsy to be in his bone rather than from his prostate because he felt he'd probably he said he felt he'd get the newest metastasis there and wanted to make sure he got the latest and greatest mutation, so to speak.
Right.
So after one failed biopsy, he got one. But I found out afterward, they only tested for 2 factors. And the 2 were, and I know it sounds technical, pan-cytokeratin and NKX3.1, which from I heard is basically establishes what we already knew, which he had metastatic cancer in his bone from the prostate. We knew that. And but I had been told from several sources that they should have tested for PSMA as well, because that might hint whether some of the other treatments might work for Barry. As a background, docetaxel, he had that first, it failed. The Xtandi failed, so he's now on cabazitaxel. He opted out of the trials for now because cabazitaxel is established, and he's decided to do that. But we're looking to the future as well. And he did get Foundation 1. We haven't come back yet, but it got sent to Foundation 1. What I wanted to find out was there any point to try to get another hospital? The hospital he goes to said all they test for is what they tested for. They don't test for PSMA or anything else. And I wanted to know if any of you had been through this and if you thought there was a point in his going to another hospital or a pathologist to get a second reading. Apparently there is enough tissue material and enough slides, so
Okay.
I don't know how much there is, but they said they have enough to test for a few things to send out. So I'm trying to figure that out, whether that's worth doing. Thanks.
Let me ask the guys quickly. Those of you who have had PSMA tests, how have they tested whether you're PSMA avid or not?
Rick, in my case, when I had my bone biopsy at the NIH, it was the NIH that determined that the biopsy tissue was avid for PSMA and PAP. So I don't know why this hospital couldn't do that, but I would definitely go to someone who tells you that they can't do it, because it is important.
Peter, what about you? Because you've had PSMA scans.
So I thought that's good to hear. That's good to hear that you're backing up on that. I did contact, someone suggested Duke University. Do you know of any other places that might be good people? Because at this point, he's got bone metastases like a Christmas tree from here all the way down to there.
Well, yeah, I mean,
no other organs, and he's not symptomatic, strangely enough. I don't know why, but I'm not complaining, but we want all the information we can get.
Right, so where are you located again? Remind me.
Could you repeat? I'm sorry, my sound went out.
Where are you located?
Excuse me?
Syracuse.
Syracuse.
I'm sorry.
Rochester.
Right.
My town just went out. I'm sorry. What were you saying?
Okay.
University of Rochester. The consult, all the other consults we spoke to said to get his treatment there to begin with, but I think I've had it when they said they wouldn't test to that. Any of the suggestions, at least where to send the biopsy tissue?
Barbara, let me suggest you turn your camera off, because it sounds like you're having bandwidth problems there, and you might get a better audio if you turn your camera off. So I think you could send it.
Okay, I will do that.
Okay. I think that you probably could send it to Dana-Farber, to Memorial Sloan Kettering. You know, the thing is, you're going to have to establish a relationship with those hospitals. Those would, you know, one of those two. I know last week we talked about Memorial Sloan Kettering satellite. That would not be my choice. You know, possibly or possibly Chicago.
No.
But a lot of these hospitals should be able to test. I do, by the way, Barbara, please send me your email so we can get you onto these lists. So we can let you know when the meetings are. We don't have it. That's okay. I'm doing it for you. Rather, not for us, but I want to be sure you know. And we have a caregivers meeting tomorrow night as well, by the way, at the same time. So
yeah, thank you. I'm in another caregiver support already. I'm in another one already.
Okay.
I'm right now in another caregiver support, so I'm happy with that. However, that doesn't, you know, the other question is, are there other things you think I should ask them to test for aside from PSMA, or should I let them decide?
Well, not if you're getting a foundation, not if foundation medicine is going to sequence the tumor for you. You should have everything back from them. But for the PSMA, to determine whether it's PSMA avid, Len, where would you send that?
I honestly don't know, Rick. I imagine you could do a Google search on it. If not, just call around.
Yeah, I think what I would do is look. What you want to do is go on clinicaltrials.gov and see who is doing a PSMA gallium scan, PSMA gallium 68 scan. Look at all the options and see if there's anybody close to you who's doing it. and then call up that facility and ask them if they could test a sample to see if it's PSMA avid.
University of Michigan, Ann Arbor.
Are you saying to do, are you saying
So David Muslin is
by
saying
the
University of Michigan, Ann Arbor.
would he need an extra scan then, the PSMA gallium scan, or would they be able to look at his, because I thought, look at what came out of his biopsy this time?
So the answer is you're not really interested. You don't need the scan. You just want to know if he's PSMA
I
avid.
didn't think so.
Because if he's PSMA avid, he's a candidate for lutetium. That's the only reason you want to know. You don't need the scan. You need to know if lutetium is an option for him.
Thank you. I didn't think he needed, I really did not think he needed that scan. We've established relationships with Cleveland Clinic, Cornell Weill, and Sloan Kettering, and partly Johns Hopkins when we were first getting consults to see where we were treated. So I'm hoping one of them will be able to do the job. But if not, we would contact Dana-Farber.
Like I say, why don't you look to see which one of them is running which one of them is running a gallium scan. And whoever of them is running a gallium scan, that's probably where they could test it for you. Okay, got to move on. Okay.
You have taken care of me. You have taken beautiful care of me. Thank you.
Thank you. Come back next week. Tell us what you found.
You have taken perfect care of me, and I'm delighted. Thank you so much.
Thank you. Send us that email, please. info@ancan.org, so we get you on our list. Okay. Ron Chin, are you with us?
Yes.
Good night, everybody.
Good night. Okay, Ron.
I'm here.
I finished up your story after you left, and I asked the guys to hold you in their thoughts, and we will give you some feedback right now. I've told them that Metzger told you only had 6 months, and I also told them that I suggested you get a second opinion from UCSF. So let me open it up to whoever would like to give your feedback and your thoughts to Ron.
Go ahead.
I'm waiting for him. They've gone silent all of a sudden. Go ahead, Len.
Yeah, so Ron, I can't recall if you were already screened for mutations or not.
Mutations meaning that the cancer got escaped.
No.
No, I mean a gene sequencing of your tumor cells
only germline.
He had germline?
Yeah, I'm pretty dumb on all of this, almost all of it. So you're going to have to tell me what you mean by all of this. I'm pretty stupid on all this.
Okay.
So did you have a blood test where they told you you have no inherited genetic mutations?
Well, they did the spit test and they got a blood test, but nobody told me nothing.
Well, okay, so you need to ask your oncologist if they have done any gene sequencing on your tumor cells, which would be somatic sequencing, or on your blood, doing check to see if you have any inherited gene mutations.
They did the blood test. They did the blood draw, and then the spit test all in one day. But then nobody came back to me and said nothing.
Okay, we'll find out. You have to ask, what was the result?
Exactly so.
Yeah.
Okay. Jeff Dreyer, can you work with Ron to make sure that We need to find out if they've definitely done germline, but we have no idea if they did a liquid biopsy or if he's had his tumor sequenced. He should get a solid tumor sequence from Foundation Medicine on a recent bone met.
Right. Okay. Yeah, Ron, I can come with you to talk with your doctor if you like, or yeah, let's stay in the loop on this and close
Okay.
contact. Okay.
Okay. Now
Okay.
that is we don't know. The blood could have been sent off for a liquid biopsy of the tumor. We don't know, or it could have been sent for other reasons. But ideally, what he wants is not the liquid biopsy, although he does have high enough PSA, but you really want a tumor. Anybody else would like to say anything to Ron? Any thoughts on this 6-month malarkey?
Well, I wouldn't put any faith in that prediction, that's for sure,
Yeah.
because nobody can foretell the future. What I'm not clear on, Ron, is did any of the therapies you've had bring down your PSA, or are they all ineffective?
No, one of them did. I was first off on Lupron, and then let's see, there was a second one there. It'll come to me when I'm not.
Zytiga, abiraterone.
Zytiga, that's it. Okay, and so took that, nothing. And then he said, this is Dr. Metzger. He said, okay, well, now we're going to go try some Xtandi. And at that point, the numbers were something to the effect of maybe 1,300. And came back about, I don't know, month later, 2 months later, or something like that, with a blood test, a PSA count, and Metzger said, hey, good luck here. It dropped 1/3 from 1,300 down to 800. We said, great. And so waited a while, did another blood test, and he said, well, too bad, it went back up. And then, so that's where we stood then. And he said, and I kind of said, well, then, well, we did chemo. Same thing, nothing. And that was before the Xtandi. So Xtandi was third in line. Chemo was third, and Xtandi was fourth. And not a peep out of the chemo, but we only did, I think they were IV injections, and I think we only did 3 of them, 4 at the very most. And he said, we ain't getting nothing out of this. And I said, well, let's stop then.
What? Rick, Lynn, would you suggest I try to get all these records and look through them?
Well, I think 2 things. I think number one, it would help if you could assist Ron in ordering his records, because he doesn't even have a good handle on that.
Okay.
Secondly, that you do need copies, both digital and paper, of all his records. And then the third issue is he's got to get a second opinion.
Right.
And if not, and maybe even switch his doctors to UCSF. I suggested that he tries to get an appointment with either Agarwal, Friedman, or Borno, one of those 3. Preferably Agarwal or Friedman.
Okay.
Did you ever see Agarwal? I'm trying to remember.
No, I didn't. I saw Koshkin. He's a new guy. Do you know of him at all?
No, I don't.
Okay.
Okay. So, Ron, did you try at all to call UCSF this morning?
I didn't get a chance. I went to my X-ray appointment, radiation appointment, excuse me, and I tell you what, it just it wipes me out, beats the shit out of me when I take those things, and I don't sleep very well at night. So I am going to do it as soon as I feel like I've got the go power to get over there, and I also have to arrange a ride, which I think I can get.
Okay, well, I think maybe Jeff can help you. And Jeff, we need to call over to UCSF as soon as we can and get him in to see one of those docs. Okay?
Yeah. Okay. Yeah, Ron, let's work on this. Yeah.
Definitely. Okay.
Okay. All right. I'm gonna keep moving on. Jeff, feel free to reach back out, but let's try and get you into a pattern where we can see what can be done for you. Okay.
Sure.
All right. Mr. Jackson, you had a very quick update for us on your PSA. What is it up? Is it down? Where is it?
PSA is up to 2.49. The NIH PSMA trial is on hold. Found out there may be something here in the local area that's also doing the same trial. So we're checking into that.
Okay, so this is as of 5:20, you're up to 2.49, which is, so it's creeping up. It's not moving up very fast, but it is going up. Is that right?
It went from 0.1 to 0.2 to 0.6 to 1.9, 2.2 to 2.49.
Right, so it's gone from 2.2 to 2.49 over 2 to 3 months.
A couple of months.
Right.
It's slow. The acceleration has slowed down.
Right. So I think, as you're saying, we need to get you in to do a PSMA scan somewhere.
Working on it.
Okay. Anybody else have anything they want to say to Mr. Jackson? I want to say Mr. Jackson does a fantastic job on the Speaking Freely call. And if you haven't joined it, you should be joining it. And when's the next call?
Thursday night, 8 p.m., same chime, same channel, same location.
Thursday night, come on in. It's a wonderful call. We don't talk about anything too technical. We do talk about what it's like living with cancer. And if you've recently got diagnosed and you feel like you're a deer in the headlights, this is the call for you. And if you don't feel like a deer in the headlights, it's still the call for you. Anything you'd like to add to that?
We're always open to additional suggestions. We do try to stay away from the technical as much as we can. It's more coping techniques, thought processes. And the last time I talked to anybody that actually knew anything, there was no expiration date on anybody in the world.
Thank you. Thank you, Mr. Jackson. And there's always a very nice dose of dry humor injected into the call. It is at 8 o'clock on Thursday, 8 o'clock on Thursday, on this same channel, in the Barniscus room, exactly the way you got in here. That's where you'll see us. Okay, moving.
Hey, Rick,
yes.
just like to get in a quick question for Rich. Are you still trying to get into that NIH trial with Yolanda?
Yolanda has been told to go home. She does not have access to her FedEx. She's not accepting any input for data to sit in. They're not adding anyone to the trial. The last email I got from her a day and a half ago was good luck. keep me informed.
Rich, this is Peter. I know it's on the opposite side of the country, but UCLA is doing gallium-68 PSMA scans. It's the only place I know that's open and doing them again. And it can happen in one day. I mean, if you trust flying, you can fly out there, get off the plane, and do a scan, and come back that night or the next morning or whatever. You got to pay out of pocket. I don't think insurance will cover it. But UCLA is back in action with PSMA scans.
Okay, thank you.
And I would encourage you to see if you may be able to get TRICARE to cover it. They're so good that you might get TRICARE to cover it.
Make them say no.
Exactly. That's the worst they can say is no. Exactly.
Rick, incidentally, I have a partnership, Medi-Cal.
You have Medi-Cal, did you say?
Yeah, they call it partnership, I guess.
Yeah, okay. That's good. Well, I mean, again, you and Jeff are going to be working together, so I'm pretty sure that you will be, if you are accepted by Metzger and Bennett, you'll be accepted by UCSF.
Okay.
So, okay, I'm moving along. Jeff Dreyer, talk for yourself. Just give us a quick update on how you're doing, because you're a fair ways out since you stopped your treatment now, correct?
That's right. It's been over a year since I finished the, since I finished the Standy and Lupron and all of that. And so last August, my PSA had gone from undetectable to about 0.135. So I was a little concerned at that time. Testosterone had recovered totally. Now I finally, after trying to get connection, there seemed to be a lot of chaos going on over at the UCSF Red Onc. I don't know, personnel changeover and things. Finally, I got reconnected with the trial people and got tested again just 2 weeks ago, and my PSA is now at 0.077. So yay, it went down again. Testosterone also went down some. It's still in the normal range, but I don't know why that is. It went down significantly. And I wonder if that's why my PSA went down. So anyway, things look good, I would say, except for that one question mark. I talked with Dr. Wong on Wednesday to go over these numbers. That's where I am.
PSA fluctuates like crazy, even within the day. There are huge fluctuations.
Testosterone, Rick?
Testosterone. So
yeah.
Yeah, you said PSA. Okay.
Sorry, I meant testosterone. I'm sorry. Thank you for correcting me, Len. Yeah, testosterone fluctuates like crazy. Yeah, I see that you were at 533 back in August. What was your testosterone this time?
Okay, this time it was 389.
Yeah, I mean, that's, from my experience on my recovery, that's not unusual. That's within the same ballpark. It depends on the time of day. I don't know. Len, can you comment on fluctuations in testosterone?
I'm not overly familiar with the exact reasons for it, but it can indeed fluctuate. Mine, when I was on drug holiday, mine fluctuated between 600 and 900 from one testing period to another. Nothing really had changed that I was aware of. But, just know that it does fluctuate a lot. I suppose, it may depend on how recently you had sex or orgasm or whatever. Hydration, who knows? Exercise, all these things can affect the testosterone level.
Okay. Well, I'm not overly worried, but anyway, I'm very happy with that PSA result for now, so I'll take it.
Yeah, I think, you know, you could easily test at 500 if you want next time you test. It's not that meaningful. All right, I'm gonna keep pressing on here. Scott, what tell us what you'd like to talk about today.
Thank you, Rick. I just I'll be getting my Lupron. I'm trying to read my notes because I was reading this, but I'll be getting my Lupron shot June the 4th. I'm on Zytiga and prednisone, and I haven't yet scheduled for the Zometa, and I'm going to go next week for one more second opinion. But I was told no to radiation, but I just want to make sure. There's one thing I want to make sure. I made a donation, and it's not about me, in your honor, to ANCAN. And I just want to know those guys got that check. I think that's my most important question.
Oh, okay. Well, thank you. If you sent a check, it would have gone to our Secretary Treasurer, who is in Minneapolis, and she's also a volunteer, and she will probably send you a receipt back in the mail because she doesn't have your email. I will send her a note afterwards and ask her if it's been received.
The main thing was to honor you.
Well, thank you.
And I will continue to do that. It's just I just want to make sure it got there. That's all. Man, thank you for your time.
Thank you. No, we'll check with it. So the question I guess I've got for you is, you're not going to do the spot radiation. We've kind of established that. Have you had any discussions with anyone about whether chemotherapy is a good option for you, and would you consider chemotherapy?
I absolutely would do whatever, but at this point I've had two second opinions that said no to chemo.
Okay.
I'm just, and I'm going to go next or tomorrow to. It's not like I'm shopping around. I just want to make sure, and I have asked that same question. I have a list where I give them the, like you said, the questions, and that's right there. Would you consider chemo? And both doctors have said no.
Who were those doctors that said no?
It's Dr. Singh at let me pardon me. I don't want to take your time trying to.
That's okay.
It was Dr. Chen at what do you call it? Honor Health with Dr. Singh and Dr. Chen with MD Anderson in Sun City West.
Okay, and what type of doctors were both of those doctors? Dr.
Singh is a community oncologist. Dr. Chen, who used to work with Dr. Moore, who's at Mayo. Dr. Chen is I'm not very good at saying this, that
a GU
there you go.
Yeah. Okay, and but you haven't seen Dr. Moore yet, correct?
I'm going to see Dr. Moore on Wednesday.
Okay, so I think that for me, Dr. Moore would be a more definitive issue, and I think the question to her is, look, I have fairly widespread. I have more than 5 or more Mets. Do you think I should be doing chemo right now? And see what she says. If she says no, she's happy with you staying on Zytiga, that's what you do. If she thinks you should consider it, then we can talk about it. But it's on the agenda. Anybody want to comment to Scott on this issue? I guess not.
I guess not. Rick, thank you for framing the question, and I will definitely do that.
Okay. All right. Dennis Correa, did you want some time? I put a tick by your name. Did you say yes?
Yes, I do.
Thank you. Go ahead.
Okay, just a quick one. It's a little different out of the norm, but I have my abiraterone acetate, comes out of a Humana specialty compounding pharmacy out of Ohio, and they overnight deliver it to Phoenix, and I get it the next day. My shipment, which was due on the 12th of this month, last week, never showed up. And I checked they go through the website, Humana, that gets you over to the UPS tracking, and it showed it was supposed to be delivered that night. It never showed up. The next day, the same thing, it never showed up. So I then called the Humana rep. She was a pharmacy technician and in their tracking department. So she said they were having, UPS is having a problem at the Phoenix terminal because of the COVID-19 and the increase in their workload, the deliveries, because of people shopping online. So they've been overloaded, so she says, and they didn't have enough workers. So the stuff has been sitting there, and I've been checking. I just checked with her again today and the tracking website, and it still hasn't been shipped. I'm fortunate that I anticipated with this coronavirus possibilities of holds up on my shipments, because this drug initiates in India.
Yes.
Comes out of India. That was the main reason I was concerned about it. I hadn't thought about this holdup with this UPS situation. So I'm kind of in limbo right now. I'm lucky that I do have enough on hand, so it's not an urgent issue. But I'm also concerned because if it's sitting in a tractor trailer in Phoenix for over a week, I'm concerned about the temperature concerns. We talked about this before.
Yeah.
And that's why they ship it overnight generally too, also, so it doesn't have to get exposed to temperatures, high temperatures. So I'm kind of just in limbo here, waiting to see. I mean, I've probably got a few more weeks of drug supply.
Well, I know what I would do. I'd be calling Humana and saying, send me out another shipment, choose a different shipper. I don't want that drug because it is susceptible to the heat, and it's been sitting in a container in 100 degrees air temperature. So it's a lot hotter. It's no good.
Yeah, that's exactly what I told her today, Rick. So she said, let me make a call and I'll get back to you. Needless to say, she hasn't got back to me today. That was this morning. So I'll start over again tomorrow with the same process. But I said, find another way. And then first she said, well, we can't use the U.S. Postal Service. I think that's crap. I don't know that there's any restrictions about using the U.S. Postal Service. She said, because of this drug, there was some restriction they could ship to the U.S. Postal Service. I don't believe that.
I think you need to escalate this, Dennis. Go, ask to speak to that pharmacy tech's supervisor, manager, because this is unacceptable.
Yeah, that's my next step, Glenn. That, and also one of the local TV stations here, when I was searching online about this issue, this investigative reporter that works for local Channel 13 News here apparently did a story about what I just told you, basically, that UPS is having all kinds of problems. They've actually canceled their guarantee program. They used to have a guarantee program on delivery. They just suddenly canceled it. So I'm going to send her an email. While I want to raise the issue and get this thing resolved, it's not like for me, it's an immediate crisis not having the drugs. But I do want to, follow up on it. But something to think about as far as anybody else is, that's getting stuff through the mail or other private shipping, to make sure you have it on hand. I order mine so it comes in at least 3 weeks before I'm going to need it.
Right. Well, I think it's more than that. It's that if you are expecting your drugs from a specialty pharmacy, you sort of follow the delivery to make sure that it doesn't get stuck along the way anywhere. This is a good heads up for everybody who's on Xtandi or Zytiga or a POP or any other, just to make sure that you stay on top of it and then you push at the right time.
Dennis, this is Jerry. I get my Zytiga and prednisone from the Mayo Specialty Pharmacy in Minnesota, in Rochester. They, just so you know, they use FedEx, and I've not had one problem. They show up on the date that we set, and they showed up in the morning every time. So that's just, tell her about FedEx.
Yeah, that's a good point. I was going to plan to investigate that.
Betsy delivers mine too, Ted.
prednisone comes in by the U.S. Postal Service from a different location. Comes from a regular Humana pharmacy. Actually, it's in Phoenix. And that comes in the.
What drugs come in on a regular? Just your
prednisone.
Oh, your prednisone. Yeah. Mine come in regular post, but it's not. Now Dell asks a really good question in the chat window, which is, are there other compounding pharmacies? There are many compounding pharmacies or specialty pharmacies. And we plan to do a webinar on them when we can find a speaker. Because to me, they're one big black box. Normally, these compounding or specialty pharmacies are associated with particular insurance companies, and very often they are subsidiaries and owned by the insurance companies.
That's the case with Humana.
Yeah,
that's
so Optum RX, for example, is the United Healthcare one, and as Jerry said, Mayo has theirs, and they all do. But who knows what the heck they're doing, and they all operate slightly differently. But I think you just have to. You don't usually get a choice. I've had specialty pharmacy people tell me that you can indicate where you want them to come from. But this is one of the reasons why we want to do a webinar, to try and unpack this a little for everybody. Anybody else want to make any comments on compounding or specialty pharmacies?
May I ask a question to Dennis?
Yeah.
Dennis, I have Medicare and WellCare and Blue Cross Supplement. What drug plan do you have that covers Zytiga? Because that's been a huge issue for me.
Yeah, Medicare Part D, and that's through Humana. And I believe, don't remember what the specific plan is, but it's through Humana insurance.
Oh, okay, and that's your Part D. I don't know. I have this WellCare, but the Zytiga is just incredibly expensive. But Humana, is it less expensive?
Humana will not insure me for the brand Zytiga.
Right. Well, I meant abiraterone.
Originally, yeah, and they failed to. They said we're going to stop coverage, and you're going to have to go to a generic, which I did, the abiraterone acetate.
But is it affordable?
It's very expensive unless you can qualify to get some money off. But,
that's my problem right now.
Well, I'll just tell you, my out-of-pocket cost is for the first 4 or 5 months here now on this is $825 a month.
Yes, that's
for 30 pills. Now, I do have from my previous ex-employer a program for catastrophic drug costs. So I will get back up to $5,000 a year, approximately, maybe a little bit more than that.
Yep.
I'll get refunded from them.
Thank you.
Len, go ahead.
I was just typing a message to Peter. What do you want me to go ahead with?
Oh, sorry. I saw that. I saw your microphone come on, and I thought you wanted to say something.
Oh, well, I guess all I would add to Dennis is, fortunately, being that you're taking abiraterone, hopefully it'll never come to this, but you can always just take one pill instead of four with a fatty meal, and it's, from as far as we know, it's just as good. So that'll stretch your supply out, but I doubt it'll get that bad since you said you already have a couple of weeks
Yeah, I
supply.
don't think he's gonna get to that. I'm pretty sure they're probably gonna ship me another shipment from another means, and I'm glad to hear when I talk to her again, I'll mention Federal Express as an alternative.
Yeah, and Scott, that's
Yeah.
something you can talk to Cassandra more about, is can you economize by taking the pill with a fatty meal? Because there's plenty of evidence on that, and we believe the absorption is very comparable. And that way you stretch out so it becomes a lot cheaper for you. Now, the one thing I did want to say is that you do have, whilst it's expensive right now, you do have this donut hole, and once you go through the donut hole and you've spent a certain amount of money on the abiraterone, I think it's about $4,500, then the price will drop down significantly.
Right.
I've never understood the donut hole. That's something I got to learn.
Okay, anybody want to just, who's experienced the donut hole can just help Scott?
The amount changes every year, and it's usually on your explanation of benefits statements that you get every month from your drugs insurer. You know what I mean? You get it in the mail or you get it online from whoever's insuring your prescription drugs. And that document will say what the amount is that you have to reach before you move into that next stage, where the price then goes down.
Okay, we will keep moving along here. Dennis, maybe would you be willing to help Scott a little bit in trying to understand this a little better? Can he give you a buzz offline?
Absolutely. If you'd like to do that, Scott, I could give you my number right here. I have no problem.
Or likewise.
It's area code's 520-744-8189.
Okay, thank you. We have two gentlemen left to touch base with, and we will see both of them. We will move quickly. One is Joel Blanchette and the other is David Muslin. Haven't forgotten either of you. So let me start with Joel and we'll finish up with David. Because Joel got on the call just before David did, so I feel I have to respect that. Go ahead, Joel. Tell us what's on your mind tonight.
In the interest of time, I'm just going to cover my last ESA. It did drop from 1.3 to 1. So from a high of 1.76 after 3 shots of SDRT, 3 treatments of SDRT, it's now back down to 1. So I asked Dr. Antonarakis at Johns Hopkins, should I continue with a 1-month PSA or switch back to 3 months? He said, go ahead and switch back to 3 months. I also asked him this positive immune response, how long does it usually last? He says it usually lasts from 3 months to 24 months, with an average of 12 months. He says, let's hope you're on the outer edge of that. And so that's the information I had for you. So I'm hoping that I can reach 0.01 again, but we'll see.
Okay, so this immune response we're talking about, for those of you who are not familiar with it, is something that's sort of called the abscopal effect, or the fact that the the radiation, when you have radiation, can actually stimulate the immune system and cause the T cells to interact and become active and interact with the tumor and kill it off. And that's what we're talking about. That's what we believe has happened with Joel, and as does Dr. Antonarakis. Correct, Joel?
Correct.
Go on. Did you have anything else? That was so quick and you were so good that if you got another question, slam it in quickly.
No, I'll wait till next time. Thanks.
Okay. Okay. And David, muslin.
Okay, so I got my blood test back, and just to give you a quick history, when I went on the Lupron February 1st of this year, my PSA was 1.4. 6 weeks later, it came down to 0.30, and last week it's down to 0.20.
Okay.
And my testosterone is at 10.
All good.
All
you know,
good.
You're heading in the right direction. I mean, what we'd love to see is for it to get down to undetectable.
Yep.
We love to see that because that is a great prognosis. But you know, we have men that go on. You heard one tonight who went on Lupron and never got the response that he wanted.
Yep, I heard that.
You know, I think that there's reason to be optimistic and see how long you stay there. Len, what would you say to David?
Yeah, steady as she goes. Just keeps going down.
Yep. So I'm going back to Chicago on Friday, and I'm going to see Hussein in about a month, and she's talking to the radiologist to see what type of scan on these two mets that I have on my ribs, whether it's going to be a CAT scan or an MRI. So she'll talk to me after she speaks to the radiologist, and she'll also order a bone density test when I get up north.
When was the last bone density test?
I've never done a bone density test before.
Oh yeah, you definitely should get that.
Right.
I mean, I don't understand why these docs don't order it de rigueur. It should be, you know, the guideline is if you're putting a man on Lupron for more than 12 months, you should do a bone density test. Yeah. And I'm the best example because I found out I was osteoporotic and I had absolutely no idea.
Right.
I've never knocked me over with a feather.
Right. And I have to tell you, Rick, if it wasn't for our call last week where you asked me about the bone density test, I asked her about it and she said, yeah, we should do one when you come back up north. So thank you for that. But in the meantime, everything's moving in the right direction. And I got over my ass hurting last week. If you remember, I got, you know, the bad shot in my ass. So 4 or 5 days it was gone. And dealing with hot flashes, and I feel great.
Okay, well, you heard it here first. We told you it would be gone. We said it would be gone by the time you talk to us next week, because we know we've done it. That's why we love your advice.
Yeah, all good.
Dell, you have a quick question.
Yeah, I have not heard about doing a bone density test. Is that something I should be concerned about?
Yes, it should.
Okay.
You should. So the reason why is because we know that long-term androgen deprivation therapy can affect your bone density.
Yeah, no, I know that. And so all my urologist is recommending is vitamin D supplement, daily vitamin D supplement.
Well, I mean, look, again, I'm a good example. I'm very athletic. You know, when I got diagnosed, I was exercising a huge amount every day. I never thought I had any issues around bone density. Now, if I think about it, my dad had a problem with it. My sister had a problem with it. My dad didn't know he did, but he shrunk hugely. My sister did know and was taking meds. I should have realized, and I have very high calcium. I have very high serum calcium levels, and sure enough, you know, my bones leach, and I was borderline osteoporotic. So even though I didn't have metastasis, then they put me on an annual Zometa infusion. I got 3 over 2 years, and it helped reverse my bone density. So the answer is yes. Anybody who has not had a bone density test and is on long-term ADT, please ask for one. And you don't need them that often. I mean, I think I was doing them annually, but you can even do them even less than annually. And then once you're off the ADT, you probably can do them every 3 years.
Okay, thanks.
Every 2 years, I do mine, Rick.
2
And
years.
it's a very easy test. It's no radiation, I don't think. It's very inexpensive also.
Yeah.
Okay,
Peter,
thank you.
pleasure. Peter, you wanted to say something to Steve.
Yeah, Steve, just as a point of information, 2 years ago through my medical oncologist, I did a quick genetic test from a company called MIRA Labs. It was a research doctor who ran this, and it gave you a percentage of risk involved in reaction, or a grade 2 reaction or greater to taking a PD-1 or PD-L1 drug. So there is a test for that. I came out at average 26%. There's a moderate and there's high. So there's a way to predetermine that, which you might ask your doc if you can access that in terms of this trial you're thinking of.
Well, they're supposed to start screening the trial. I hope that's part of the screening. So maybe they'll tell me what my average would be.
It's a pretty.
But I did want to.
Hold on 1 second, Steve. Just what's the name of the test again, Peter?
It was through MIRA Laboratories.
How do you spell that?
MIRA.
MIRA Laboratories. Okay.
And the researcher is Dr. Richard Gatti, Gatti. It's in Los Angeles. It's a pretty obscure test, and it's and I don't know how widespread it is, but I did it 2 years ago. And based on different biomarkers, it tells you where you fall in a category of risk of developing grade 2 or higher.
We got it. I need to move on because Steve, you wanted to say one last thing, and then we close.
Yeah, I'm new. I'm just wondering how do we connect peer to peer? I'm not sure about that.
How do we what?
Is there a way to connect peer to peer?
If you write to me and tell me who it is you'd like to connect to, I will connect you, or you can ask them right now. Who would you like to talk to?
Well, I'd like to converse with Dell and I believe Ken, because Dell, I mean, I've been told surgery is out of the question for me, and now he's having surgery, and I think it was Ken was talking about radiation. So just like to talk about that. I mean, I'm just starting, but I want to know. They've told me that's not in the works right now, or when is it possible, or is it not possible?
Okay, so those are both good examples. Dell, would you either are you comfortable giving Steve your email, or would you like me to send it to him, or your telephone number, or what?
You can go ahead and share both if you have them.
I will.
That's fine.
I will send them to you afterwards. Ken Anderson is Ken_Anderson at ancan.org. And Ken had radiation. He had radiation to his gland after he'd done chemo. And we just had somebody else who, my mind's going blank, who just finished. Oh, Dennis McGuire just finished. Dennis McGuire, who's a younger guy, just finished. So start with Ken and Dell, and I'll connect you, and then we'll go from there.
All right, thank you.
Pleasure. And by the way, guys, when you're on this call, you can send messages through the chat window directly one to another. So, you know, you can always, I don't even see them, but you could send Dell a message and say, Dell, can I connect with you? And if Dell was watching the chat window, which he has been very diligently, he would answer you. So feel free to use the chat window as another way to talk to each other during the meeting. Guys, thank you very much. It's, you know, we're only 15 minutes over, not so bad. We'll meet again next week on Tuesday at 6 o'clock Eastern time, whatever that is. And I wish you all a good week and a cooler week than us Arizonans are going to get. Okay. Goodbye,
Thank you, Rick.
everybody. Good night. Good night.
Good night.